Rahman Rahim. Hello, everybody. It's a great pleasure to join this prestigious conference of the Arabic Association for the Study of Diabetes and Metabolism. It's actually an elegant conference, an elegant meeting with a joint efforts between the endocrinologists, diabetologists, and the cardiologists also. And I'd like to thank Professor Ines Sheltut for this kind invitation and Professor Atif Al-Bahri for moderating this important session. My presentation today actually is about a very important topic, which is also an everyday practice topic, the chronic coronary syndrome in diabetics. And I think we have a very important stations that we have to know for the management of such a critical long-term problem. As a fact, we have to know that within the last 2 decades, the number of patients with diabetes quadrupled from 108 million to 422 million. Imagine. And this was only in the year of 2014. Imagine the situation now in 2020. The link between diabetes and cardiovascular disease is strong, as diabetes increases the risk for coronary artery disease by 2 to 4 folds. This is another important critical point. It is estimated that around 80% of those with diabetes die from cardiovascular causes, mostly from our problem today, which is the ischemic events. A very important initial station is to categorize the diabetic patient, because by categorizing our patient, we will put the plan, we will put the strategy for better management of the patient, for better outcome. We have to know this is the European Society of Cardiology classification and the categorization of the risk of the cardiac patients. These patients with diabetes and established cardiovascular disease, and as we all know, the patient with chronic coronary syndrome is considered to be a patient with established cardiovascular disease. So if we have a patient with diabetes and established cardiovascular disease, we have to know, we have to consider that this patient is very high risk patient. This is a very important initial station upon which our decisions will be made on. And the first step in management of those patients, as we all know, we have to know that the station of lifestyle modification is very important, it's very vital, it's very pivotal for treatment those patients, management for those patients. And as a class 1 recommendation level of evidence A by the European Society of Cardiology, moderate to vigorous physical activity, notably a combination of aerobic and resistant exercise for 150 minutes per week, is recommended for the prevention and control of diabetes, unless contraindicated for any severe comorbidities or a limited life expectancy. Also, a very important point here to mention is the Mediterranean diet, rich in polyunsaturated and monounsaturated fat, should be considered to reduce cardiovascular events. We have to consider the diet habit of the patient. We have to advise him about the best diet for prevention of his cardiovascular problems and events. Also, we have to know here that vitamins or micronutrient supplement to reduce the risk of diabetes or cardiovascular disease in diabetes is of a class 3 recommendation. No rule at all for the micronutrient or vitamin supplementation for those patients for cardiovascular disease prevention. Again, here we have to know a very important point, that it is recommended to apply tight glucose control targeting near hemoglobin A1C less than 7, which is about 53 millimole per mole, to decrease the microvascular complication in diabetes. That is class 1 recommendation by the European Society of Cardiology. So we have to remember this figure. We have to apply this figure that hemoglobin A1C should be less than 7 for or to decrease the microvascular complication. This is a class 1 recommendation. As a class 2A recommendation, that hemoglobin A1C target of less than 7 should be considered for prevention of macrovascular complication also in individual with diabetes. So micro and macrovascular complication will be better prevented by reducing the hemoglobin A1C to less than 77%. Here we come to the revolution in medicine in the last decade, which is the use of the SGLT2 inhibitors as a glucose lowering treatment and for also prevention of cardiovascular events. Here, the European Society of Cardiology have an important recommendation, which is a class 1 recommendation level of evidence A for the use of SGLT2 inhibitors, empagliflozin, canagliflozin, dapagliflozin, which are recommended in patients with type 2 diabetes and cardiovascular disease at very high risk. And I'd like to remind you that our patient today is a chronic syndrome with diabetes, so he is considered to be a very high risk. So we have to use for the glucose lowering treatment those with like empagliflozin, canagliflozin, dapagliflozin, the SGLT2 inhibitors. Also, the empagliflozin is recommended in patients with type 2 diabetes and cardiovascular disease, not only the morbidity and the events, but also to reduce the risk of this with the same level of recommendation, which is the class 1 recommendation. So we can see how important those group of drug in the prevention of the cardiovascular events and the risk of this for in diabetic patients. Another important group also at the glucose lowering treatment, which are the GLP-1 receptor agonists. The liraglutide, semaglutide, and dulaglutide are recommended in patients with type 2 diabetes and cardiovascular disease, also at very high risk or high risk, to reduce the cardiovascular events with a very strong recommendation, class 1 level of evidence A. So we have now two important weapons as a revolution in medicine for treatment of diabetes in parallel with the reduction of cardiovascular event and risk of death, which are very important subgroups of drugs which we can use as weapons to counteract this major problem. Again, here in the chronic syndrome, in specific circumstances, which is diabetes by the European Society of Cardiology, we have to know that the reduction of all the risk factors, all the bad guys with diabetes, like the hypertension, dyslipidemia, and we have to control them to targets. All those are recommended in diabetic patients as a class 1 recommendation level of evidence A. Again, here another important recommendation, despite it is with low evidence, but we can use it, especially in those patients with a job which is a critical job, or with who are will be subjected to a major operation. Those asymptomatic adults more than 40 years with diabetes, functional imaging or coronary CTA may be considered for advanced cardiovascular risk assessment. I think we are now using such recommendation in considerable percentages of our patients in our practice. Also, we have to know a very important recommendation here, that in asymptomatic patients with diabetes mellitus, because of the pattern of silent attacks, we have to do a periodic resting ECG for cardiovascular detection of conduction abnormalities, atrial fibrillation, and silent ischemia and silent myocardial infarction. So we have to consider the ECG as a class 1 recommendations for diabetic patients for follow-up to detect arrhythmias and silent ischemias and myocardial infarctions. Again, here the recommendations for managements for the use of ACE and ARBs, which are indicated in patients with diabetes and coronary disease to reduce the risk of cardiovascular events, was a strong recommendation. Again, here based upon a long list of landmark trials +1 recommendation level of evidence. Statin therapy is also recommended in patients with diabetes and cardiac disease to reduce the risk of cardiovascular events, with a strong recommendation here again. But this is a very important station which we will come back again to it because it is very important to those subsets of patients. Also, we have not to forget the aspirin, to give the aspirin for those patients lifelong, maybe 75, 160 milligram day is recommended as a secondary prevention for diabetes, was also a strong recommendation level of evidence A. We have not to forget for those patients who are obliged to use DABT or oral anticoagulation for their management strategy, to use proton pump inhibitor to counteract the gastrointestinal bleeding, which have to know that the bleeding per se is itself an ischemic risk. So we have to counteract it by using the gastrointestinal, by using the proton pump inhibitor to counteract the gastrointestinal bleeding. Also, the use of clopidogrel is recommended as an alternative to antiplatelet therapy in case of aspirin intolerance. We have to consider this because in a lot of patients with chronic coronary syndrome, diabetic patients, we are not be able to give aspirin because of any reason, like aspirin intolerance. We can use safely clopidogrel with class 1 recommendation. Another important recommendation here, which is the prolongation of DABT. We have to prolong the use of DABT, dual antiplatelet therapy, beyond the 12 months in those patients subjected to ACS or did PCI for up to 3 years in patients with diabetes who have tolerated DABT without major bleeding complication. Because of the very high risk nature of those subsets of patients, we have to prolong the use of DABT if there is no major bleeding complications. Again, here, as I mentioned, the very important station, the management of dyslipidemia. As I mentioned, that the patient with diabetes at very high risk of cardiovascular risk and the LDL cholesterol target, we have to reach less than 55, and the LDL reduction also can be at least 50% is recommended. Also, we have another secondary goal for diabetic patients with non-HDL target of less than 85 milligram per deciliter in those very high risk patients. So we have two important figures here to mention, to remember, is the reduction of LDL less than 55 and non-HDL less than 85 in those subsets of patients. Again, here we have to reach those targets by using the high intensity statin if tolerated, and if not reaching the target, we have to add ezetimibe, and if not tolerated, we have to use the PCSK9 inhibitor with the class 1 level of evidence A recommendations. Again, here the use of the antithrombotics. The addition of second antithrombotic drug on top of aspirin for long-term secondary prevention for those very high-risk patients, the diabetic patients, the chronic coronary syndrome, should be considered in patients without high bleeding risk, again we mentioned. And also the use of beta blockers, especially in those patients post-myocardial infarction and those patients without reaching the target of heart rate resting less than 60, we have to use the beta blocker for them to also prevent further cardiovascular events. And now we come to one of the final stations which might be obliged to use it, which is the revascularization by doing an intervention. And I'd like here to mention that it is recommended that the same revascularization techniques are implemented for those diabetic and those without diabetes. But we have here to confirm the use of drug-eluting stents for those patients. And I think now in the practice we have nothing other than the drug-eluting stents to use. It is also important aspect here to mention that it is recommended that renal function should be checked if patients have taken metformin. And as we all know, most of the patients, diabetic patients, are under metformin. So if they are pushed to the cath lab, we have to do a renal function immediately before the angiography, and that metformin should be withheld if renal function deteriorates. This is a very important issue here also to mention. Again, here another important point to mention: optimal medical therapy is the cornerstone and is the default pathway in the treatment of those patients, and should be considered as the preferred treatment in patients with chronic coronary syndrome and diabetes, unless there are uncontrolled ischemic symptoms. So we have to optimize our treatment to maximum. We have to keep it up so far no symptoms, but if there is any symptoms and uncontrolled ischemic symptoms, the patient should be pushed to the cath lab, especially if there is a large area of ischemia or significant left main or proximal LED lesions. Now I come to my final slide, my take-home slide. Here is the how we can manage properly those patients with chronic coronary syndrome or stable coronary disease and diabetes. We have to mention here that the base is the heart healthy lifestyle by maintaining an exercise of about 150 minutes per week, and to keep on the Mediterranean diet with low fat, low carb, which is very important to mention here. This is a heart healthy lifestyle as the first step to mention. Then we have also to mention that those patients with anti-anginal therapy, we have to give them because of symptoms, and also to control the blood pressure very well by using especially the ACE inhibitor and ARBs, and also to use the statins, high intensity statins, to reach the target, as I mentioned, of LDL less than 55 and HDL less than 85. And if we are failing to reach, we have to add on ezetimibe, and if we fail, we can use PCSK9 inhibitor. Also, the metformin and the innovative drugs, SGL2 inhibitors and GLP-1 receptor agonists, is a very important innovative drugs with high level of recommendation to use as a glucose-lowering agents in such subsets of patients with chronic coronary syndrome. And also the use of aspirin lifelong 75 to 160 milligrams is a very important station in the treatment of those patients unless there is a high bleeding risk, as I mentioned before. And finally, if we have still resistant symptoms despite the optimal medical therapy, which is a preferred pathway of treatment, we have to use the revascularization if the medical treatment fails. And finally, I'd like to thank you all. I'd like to thank Professor Ines Shaltut again and all the board of the Congress. And I'd like to thank my dear professor, Professor Atif Al-Bari, for inviting me for such an elegant session. And I hope to you and wish to you all a fruitful Congress. Thank you very much.